Hi, everybody. Thank you so much for joining us here at ASAP and PeerView. Really excited to talk to you tonight about retinal diseases in emergency medicine, and talking specifically about timely recognition and then referral for specialty care. We'll do a couple of introductions really quickly. I'm Robert Hughes. I'm an emergency medicine physician in Cleveland, Ohio at University Hospitals Cleveland Medical Center. I'm affiliated with Case Western Reserve University School of Medicine, and I'm vice chair of clinical affairs. Dr. Wang, would you introduce yourself?
Yeah, it's great to be here with you again, Dr. Hughes. It's a mini reunion of sorts. I'm Christina Wang. Thank you for having me. Thank you to PeerView Institute for executing tonight's program. I am a retina specialist and ophthalmologist at the Baylor College of Medicine, where I'm a professor on faculty, and I'm really passionate about the topic we're going to be speaking on tonight. So I hope you will learn something new from the ophthalmology world.
We're really excited to present to you this evening. A huge thanks to PeerView, to the American College of Emergency Physicians, to all of you for taking time out of your busy day to join us this evening and talk about retinal disease. A couple of reminders for you all. Be on the lookout for a couple of polls during the presentation. Dr. Wang and I are going to use the polls as a bit of a discussion springboard between the two of us, but we're going to want you all to participate. And then please make sure to submit your questions. What we'll do is we'll kind of source them toward the back of the conversation with the chat, and then we'll answer any questions you may have. And with that, we'll take it away. During this, we will have some resources for you. So these will be displayed at the end. We will also have an opportunity to download at the end of the event. But if you do need more information, bottom left corner of your screen there, send an email to live@peerview.com. And then on X at PeerView, they are there so you could join the conversation. All right, three goals for today, okay? And what we're going to do is we're going to kind of split this up a bit. I'm going to take the beginning half of the diagnosis of retinal disease, and then Dr. Wang is going to educate us on exactly how that sort of pans out in the ophthalmology world. We're going to enhance your ability to diagnose CRVO and MEF-RVO. So really what we're going to be talking about is retinal disease, maybe this specific bit of retinal disease, but kind of how we get ourselves through a complex differential diagnosis and ultimately land on this. We're going to equip you all with the skills to facilitate emergent ophthalmologic consultations, but to do so in a really mindful way by giving you some pointers on how to do an excellent history and physical exam. And we're going to improve your ability to educate your patients, your care partners, your staff about the urgency of RVO specifically, and then the importance of timely follow-up. All right, so first, let's focus on the thing that gives me the most consternation, Dr. Wang, in the emergency department, which is performing a basic ophthalmologic exam. When I work with the residents in the emergency department, I take great pains to force them to use the slit lamp, to force them to try fundoscopy, and to get them really good at doing a good history and physical exam for the eye. There's a lot of different reasons why getting a good examination can be difficult when it comes to vision loss. First of all, there is a massive differential, and I think we all know this. I mean, it can be the eyeball, but then there's also posterior circulation stuff that we need to be considering in the department. So when you deal with such a huge list of differentials, how do you narrow it down? That kind of goes into the next thing, which is early recognition, referral, and treatment are critical, right? So not only do we have to consider this myriad of etiologies of potential vision loss, but we have to think about what the timely follow-up is for those and how to address them. Then we deal with the resources and the tools, comfort doing the exam. Like I had mentioned, the ophthalmologic examination gives me a lot of anxiety in the department, but I felt better after deploying some of these tools, and I hope you will as well. And then access to our specialty consultants in the community. How do we align with them? How do we best partner with them? And how do we create pathways to enhance our ability to connect our patients to our specialists in the community, like Dr. Wang? So, Dr. Wang, I thought we could start off with a case here. 67-year-old female comes into the emergency department, painless vision loss in the right eye. I mean, this is really typical. This is somebody I see at least 2 or 3 times a shift. I worked just this past Sunday and I saw somebody with this exact complaint. They say that upon waking up in the morning, they have this unilateral painless vision loss. They don't have a headache. They don't have slurred speech. They don't have a history of ocular surgery or trauma. They wear glasses, but it's just for some nearsightedness. They have high blood pressure and diabetes, which is relatively classic for most of the folks showing up in our emergency department beyond the age of 60. And vital signs are relatively stable. Dr. Wang, I wonder if maybe we could talk for a bit about what we should be considering here. So in Linda's history, is there anything that stands out to you related to her vision loss that should point me in the right direction to say, boy, I think this is the pathology?
Yeah, Dr. Hughes, I think you hit the nail on the head when you started off 2 slides ago and said, that the differential for ophthalmic presentations is so huge, even though it's such a small organ. And so it is impossible to just look at a history and know, hey, this is the diagnosis. But a lot of times you can get an inkling. And the things that I'm paying a lot of close attention to when I look at this Miss Linda's history that you just presented, I'm seeing that you mentioned unilaterality. I'm seeing that you mentioned painless vision loss and that it occurred quite suddenly. And those things will start helping you sort of shape a differential diagnosis that's most likely. But you're spot on, and your trainees are so lucky to have you guiding them because part of the communication that happens between different specialists in medicine is really based on the language and the findings that we are seeing in these patients. And so without that, you're really lacking a piece of the communication. And so it's really important for next steps to actually look at the patient. But, again, I want to point out that it's always important to ask about pain, any associated systemic factors, of course, the presentation and the onset, and then the medical history. I definitely pay attention to because so many systemic diseases are manifested through the eye, believe it or not. And you mentioned two of them with her cardiovascular risk factors, including her hypertension. But honestly, those things are very, very common in all of our patients that we see. But it definitely makes me start thinking along those lines, especially given the fact that she's also 67 years old.
I'm going to tell my trainees you said that, by the way, so I could just remind them. So when I see them on shift, I'm going to bring that up.
You can
As
show
I
them.
kind of look at this case, I agree with you. The thing I like about ophthalmology, I think, is that there are very distinct questions we can ask in the emergency department that help guide us. It's a very easily built decision tree. And so to that end, I think it's nice when we could say painless or painful, unilateral or bilateral, because then I look at the next question and I say, are there any ocular diseases or conditions that can be ruled out? For me, all of a sudden, if I hear painless, I'm starting to think much less angle closure glaucoma, traumatic iritis. Am I along the right path thinking that way?
Completely, Dr. Hughes, you're absolutely right. Never say never. So of course there's always the zebras that present in an untraditional way, but absolutely when you hear painless in sort of this type of setting, common things that you would normally think about for what you probably see in the emergency room every day include things like corneal abrasion, corneal ulcer or infection, which are often related to contact lens wear, angle closure glaucoma, like you mentioned, trauma. All of these things become much lower on that differential diagnosis because of the painless word. And then same thing with, bilaterality or unilaterality, and also the way that it's progressed. One other thing I always ask about is flashes or floaters, which often accompany another painless, typically unilateral presentation, which is retinal detachments, a pathology that I care for every day. And I didn't hear that that was mentioned with this 67-year-old woman. So while it doesn't eliminate the fact that she could have a retinal tear or a retinal detachment, it definitely moves that a little bit lower on my list as well.
What I love about what Dr. Wang is saying, and hopefully you in the audience are kind of catching on here, is this third box. Was there anything missed in Linda's medical history that we might want to clarify? We kind of did this topical evaluation of painless, not painless, lateral, unilateral, or bilateral, unilateral. And what we're finding is that there are other questions we can ask that can really dive deep into what the potential etiology is for us. And what makes that great is that it gives us a nice algorithm for our history to sort of approach it. And so to that end, let's move on because we're going to talk about those next steps in the evaluation and treatment here. So we're going to gather more information about the scope and the nature of the vision loss. So I like talking about my history and doing a physical exam in kind of two different ways. So on the left side, let's focus on getting that history. So first is the description of the issue. So one eye or both. We talked about how that can really delineate what the potential etiology is. If all of a sudden I'm finding that it's a homogeneous hemianopsia, I'm starting to think a little bit more posterior circulation stuff and gearing my questions that way. Painful or painless, whole or partial visual field, like Dr. Wang had mentioned. Was it complete at the outset or did it progress? Curtain, floater, spots. All of these things can really drive a separation of our differential diagnosis and help us hone in on where we're going. The timing is a huge factor. So is isolated versus syndromic. As Dr. Wang had mentioned, the eyes are the view into the soul, right? And so they're going to show us a lot of potential systemic pathology that may be going on as well. And we had talked about the posterior circulation insults. I think that's one of the biggest ones to kind of reiterate as we talk about visual changes is that posterior circulation assessment, because I think all too often we're not covering up the contralateral eye and seeing if somebody's having the same symptoms on that side. When it comes to the physical exam, I am a simple man and I like simple things. And so the way that I break this down for people that I work with is I consider before the eye, for the eye, and beyond the eye. This allows me to start saying, okay, before the eye, what are the ocular vital signs? What's the pressure, the acuity? I'm assessing every bit of the external and internal exam. I'm moving into the for the eye portion of the exam when I'm sitting down with my slit lamp or I'm doing my fundoscopy and I'm trying to assess actual motor movements and functional assessments of the eye. I'm checking that slit lamp exam and I'm doing my fundoscopy. And then the beyond the eye, I'm doing posterior circulation testing. I'm looking in the oronasopharynx and I'm checking the ears and I'm checking the skin. I'm looking for zoster and rashes on the external aspects. I'm looking to see if there are hidden vesicular lesions on the internal or the external auditory canal on the inside. So I personally break it down for before the eye, for the eye, and beyond the eye. Dr. Wang, any pointers you can give me to do a better examination when I'm seeing patients? Is this a good way to break it down?
This is an excellent way to break it down because it is important to consider all of these various components. I would say that, we'll talk about this in a little bit, but when it actually comes to the examination of the eye, I definitely have some tips that I'll offer. One other point I will just add is history is so important. And I know we touched on that on the earlier slide, but one thing I will mention is I can't tell you how often patients forget to tell you things that are chronic about their ophthalmic history, such as glaucoma. And that's going to be an important aspect to question patients about when it comes to retinal vein occlusion, as we'll talk about soon, as being a risk factor. So sometimes I'll ask them, hey, are you taking any eye drops? Do you see an eye doctor regularly? And a lot of times you'll be surprised that will draw out information that they may have just completely forgotten to tell you. Maybe they do have glaucoma and they just forgot to mention that on their, intake form, for example. So that's another way of drawing out some important information.
Those are fantastic questions. I fully agree. All right. So we're going to move into, I think, what gives most consternation for the emergency medicine physician in the department, which is how to do a solid slit lamp exam. So when I started residency many, many years ago, I decided to do all the things that scared me as much as humanly possible. So I got desensitized to it. So I spent a lot of time with our slit lamp exam. And I broke it down into what I think is a pretty easy approach to the slit lamp. You want to start from the outside and move to the inside. So you see this sort of spectra here on the screen of starting with the lids and the lashes on the external aspect, looking at the conjunctiva and the sclera, the cornea. But much like we all have a routine when we read a chest x-ray or when we read an EKG, try to prepare yourself to have a similar approach to the slit lamp. There's a couple of things you could do that are pearls to make sure that you get an excellent exam. Number one is getting the patient comfortable. You'd be surprised how often your exam is not going to be optimized because a patient is at a 45-degree angle against the wall because the cord is just not long enough for your slit lamp. So find a comfortable place to do it. The other is make sure that the points of the patient are touching the appropriate points of the slit lamp. Their forehead has to be touching that forehead band. Their chin has to be on the chin rest. Pupils at those little black lines on the slit lamp machine. Dr. Wayne, do you have any pointers for how we in the emergency department can do a better slit lamp exam?
Dr. Hughes, those are awesome tips. And I would say the hardest part about it is that you're trying to move in all these different dimensions, but then you've got a fourth dimension with the patient. And oftentimes they just don't know how to properly position, or they're nervous or anxious and moving around. And that just creates a much harder exam than it needs to be. So I would say the number one point from all those great pieces of advice that you offered is that that patient keeps their chin in the chin rest and their head against that slit lamp bar in front of them. And that way they will keep still, so that now you're down to just moving the slit lamp as sort of the director or the captain of this ship. And then one other piece of advice I would say is there's a lot of moving parts and buttons to the slit lamp, but really just take a moment when you're not under a lot of pressure and play around with it. And I think it'll become a lot more simple than what it first seems. The other thing I would say is when you're first using the slit lamp, there's ways that you can move the slit lamp beam so that it's on angle. And we do that sometimes to evaluate parts of the eye like the anterior chamber and to gauge depth. But honestly, the easiest way is to think of it as a flashlight and a magnifier. And you want everything in axis when you first start, just to get yourself in focus, just so you're at the right position. Then you can start swinging the slit lamp beam and becoming a little bit more sophisticated in sort of the depth of the eye that you're looking at.
Two things that really speak to me that you just said was A, keeping it simple, because I think that is like the core ethos of being an emergency medicine physician. So I think we could all relate. The other is knobology. I think all of us are familiar with that first time we get acquainted with our ultrasound machine. And you spend a little time and you just kind of fiddle with all the knobs and the dials and you figure out exactly how to progress through to get an excellent ultrasound image. Same concept to me mentally, right? You spend the time with your equipment, you learn it, and then all of a sudden you're going to be really good at it. And then when I ultimately give Dr. Wang a call and I say, hey, Dr. Wang, I got a patient with X, Y, and Z pathology, it's going to increase trust. One of the things that you will find as a through theme through this is we partner with our consultants in the community is building up that trust by us being really good in the emergency department at gathering an excellent history, doing an excellent physical exam, communicating the results in a way that is tangible and can really paint a picture for the consultant. That's going to make it infinitely better for the patient and drive better patient care.
Yeah, I couldn't echo more what you just said. I think it not only helps with relationship building between what should be a very collaborative relationship and environment between specialists, but you're absolutely right, Dr. Hughes. At the end of the day, it's about patient care and being able to communicate appropriately what you're seeing, what the state that the patient is in, may make a huge difference in terms of the way we triage, who we see next, et cetera, when we're juggling multiple consultations. And that could change the ultimate outcome for the patient. So I really appreciate what you said. I'll just add one more thing is that, we are always happy to help. So anytime you consult an ophthalmologist down in the emergency room, ask him, hey, do you mind giving me a quick 3-minute tutorial of the slit lamp? We're always more than happy to do that if you're less familiar with, our pieces of equipment.
To your point, I've actually had a friend come down and do that exact same thing for me, and I was so appreciative. I had never really considered light intensity when I first do my
Yeah.
examination, and boy, was I blasting some people's eyeballs with pretty high intensity light. And I started turning it down. You can get just as good of an exam. Are there any other like pearls that I can do at the bedside to keep my patient more comfortable, kind of like that?
I think just reassuring them and maybe before turning on that light full beam, make sure that you're turning the beam away from them first and adjusting the intensity before you shine it at them. A lot of times also remember that people are pretty squeamish about the eyes for whatever reason, and they may not be as familiar with those types of examinations. Maybe they've never even been to an ophthalmologist, and so they're nervous about it. And just walking them through, letting them know, hey, I'm about to shine a lamp into your eyes. You're going to see a lot of brightness. A lot of patients get nervous afterwards when they're all sort of whited out after exposure to light. I always reassure them that is transient. It's not dangerous to be exposed to light to your eyes, and I promise your vision will return in just a moment, just a few minutes.
Those are all great pointers. So to recap here, a good slit lamp examination is going to start from the outside and move in. But the main way that you're going to have success doing an excellent slit lamp exam is patient comfort and your comfort. Optimal positioning and optimal setup is everything. Practice the knobology. Figure out how your slit lamp works. Start from the outside, lids and lashes, into the conjunctiva and the sclera, the cornea, anterior chamber pupils, iris and lens. So let's talk about the other scary examination in the emergency department. And I think we have all in the ED accepted that this is a particularly challenging examination to do. I think we all sort of laugh to ourselves when our medical student comes out and said that they did a fundoscopic exam. But I would challenge all of you to try this and get better because Dr. Wang has a couple of pointers for us that I think are going to help us do this better. And I've learned a couple things over the years that have helped me do this as well. So doing a fundoscopic exam is so important, especially as we talk about some of the pathology that our patient has that we had in our initial case, specifically because we need to be looking at the optic disc and the retinal vessels and the macula and the fovea and the peripheral retina, because this is how we're going to identify our cup and margin ratio, how we're going to identify if there's any hemorrhages or exudates. All of those classic findings that as we go along here and we talk about our differentials, clue you into what the ultimate pathology is. So we're going to watch a video here in a moment, but briefly, Dr. Wayne, do you have any pointers for us on how we can do a better fundoscopic exam at the bedside?
Yeah, and I think the video is going to really nicely illustrate some of these points, but absolutely. First of all, cut yourself a little slack because this is absolutely one of the most challenging examinations there is. And I'll tell you, without sort of the full equipment that we are fortunate to have in our ophthalmology offices, using just a direct ophthalmoscope is really challenging, even for a trained ophthalmologist, especially since I see that not all patients are necessarily dilated when they come to the emergency room, because not all emergency physician doctors may feel necessarily comfortable doing that. If you do, I encourage you to do so. That's going to be your number one tip to making this part of the examination a lot easier. And they generally are very well tolerated by patients, although it's important to tell them that their vision is going to be blurry for the next 4 to 6 hours, depending on exactly what pharmacologic you use. So that would be the first thing, is consider dilating the patient. The second tip I would say is, just like what I said about the slit lamp, Dr. Hughes, you don't want two moving parts, right? It's going to be impossible to hit that target. So you want to tell the patient and give them a target to look at across the room. And usually the best way to do that is to ask them to look straight ahead and then give them an actual target. Say, look at the fire alarm or look at the lamp, etc. And that way they're fixated while you're moving and trying to get in through their pupil. And then the third thing is, remember, you always want to start with the landmark, to look for the optic nerve as your grounding point, so you know exactly where to move out from. I always look for the nerve. And so the way you're going to do that is actually by coming towards them, coming very close to them, and then towards their nose. Okay, so that's the angle you're going to see in the video that Dr. Hughes is about to show.
Fantastic. The only other pointer that I have from my end is in a non-dilated exam, and this blew my mind, using the smallest light aperture as opposed to the larger one gives you the better picture. That was mind-blowing to me. And all of a sudden, these became a little bit easier. With that, I would like to move on to the video, and we'll do a little video demonstration of how to do a good fundoscopic exam.
Looking directly into the pupil, you'll see an orange-red color first, which is the retina. Now move around, adjusting the lens power until some feature comes into focus, and often this is a retinal blood vessel. So retinal blood vessels consist of paired arteries and veins, with the veins being wider in caliber and darker in color. Follow the course of a pair of vessels to get familiar with what normal looks like, and look for abnormalities such as vessel tortuosity and AV nipping, seen in systemic hypertension, and venous beading, which is seen in severe diabetic retinopathy. Also look for perivascular abnormalities such as cotton wool spots and retinal hemorrhages, which are seen in conditions that include diabetic retinopathy and retinal vein occlusions. Examine all 4 of the retinal vascular arcades, which emanate from the optic disc in the inferotemporal, infranasal, supranasal, and supratemporal quadrants. As you do this, track the vessels towards the optic nerve, which is located in the nasal aspect of the fundus. So remember, the nerve is nasal. Another clue is that any V shapes created by vessels point towards the optic disc. Once you find the optic disc, it will fill up most of the 10-degree view of the ophthalmoscope. Assess the 3 C's of the optic disc, which are the color, the cup, and the contour.
Welcome back, everybody. I hope that video was eye-opening. I have 2 daughters, and so dad jokes are kind of my thing, so I love them. Sorry about that. But let's move on, okay? So if you want, you can download that video and watch it. There is a small button on the left side of your screen that will allow you to view the video, and then you can also get it in the resources at the end, just to remind you all. So Christina, just to kind of refresh us on our case here, we have this 67-year-old woman, and she came in with this painless, sudden vision loss in that right eye. We got a couple of those ocular vital signs. Her visual acuity does not look awesome. I see that extra 0 after the 4. And so now I'm seeing 20/40 in the affected eye, 20/25 in the unaffected. And then together, her vision is not great. Pupils are equal, they're reactive. Her extraocular motions look fine to me. I do a tonopen and I get a couple of excellent pressures, 18. And I took all of your advice and I was able to get an excellent fundoscopic exam. And I see dilated retinal veins and diffuse retinal hemorrhages with like this blood and thunder appearance and swollen optic discs. So while our audience takes a second to do this quiz and start to sort of flesh out what we think is highest in our differential based on these, I thought maybe you and I could discuss what maybe makes some of these less likely and some of these more likely. So, right away, I look at angle closure glaucoma, and assuming I have confidence in my tonopen, and the fact that it was painless vision loss, I kind of have a lower suspicion that it's angle closure glaucoma. What do you think?
Yeah, absolutely. I think the pain versus painless fork in the road is a big one. And angle closure glaucoma, while it is linked with older age and definitely can happen in a 67-year-old patient, patients are going to present much differently. They're going to usually have a very red eye. It's going to be teary. And the number one thing that's going to have brought them into the emergency room is pain, oftentimes acutely. So, the fact that this patient has painless vision changes makes that a lot less likely.
I was impressed that we were able to get such a good fundoscopic exam. And given that we were able to get a good fundoscopic exam, as I'm looking at this, I kind of mentally am able to say, boy, retinal artery occlusion versus retinal vein occlusion. I mean, to me, I think I can make some judgments on that. But what should I be pulling away from our fundoscopic exam in terms of differentiating some of that?
Yeah, really great question. So thank you for doing such a thorough examination, Dr. Hughes. And, the fact that you mentioned the blood and thunder appearance, that's really very pathognomonic for central retinal vein occlusion. But let me explain some of the differences. So, you might not know that right away, especially if you don't see this disease every day. But one thing that you will notice are the diffuse hemorrhages that you've seen. And you may not even, immediately think about a blood and thunder, quote unquote, appearance, but you see obviously that there's patchy redness throughout the entire retina. And when you see that, you can already strike two of these from the list. And that would be amaurosis fugax and central retinal artery occlusion, which look a lot different. Those two conditions are due to some sort of embolus that has blocked off a central retinal artery or an ophthalmic artery, which feeds the blood supply. It's the arterial supply to the retina and all of the eye, actually, for the ophthalmic artery. And so those look different because a lot of times they'll present more with a whitening of the retina. You won't see necessarily a diffuse hemorrhagic appearance, the way that is very consistent with a CRVO or central retinal vein occlusion. I will say that one of the things that can look a lot like central retinal vein occlusion, because it is associated with hemorrhages, is diabetic retinopathy. And I would say that most people know that with diabetic retinopathy, it's one of the most common retinal conditions that we see because diabetes is so prevalent nowadays in nearly 10% of the United States population. But you can have a variety of different types of hemorrhages, including microaneurysms, intraretinal hemorrhages, et cetera. But for patients with a more advanced disease, they can be scattered across the entire retina, very much like central retinal vein occlusion. However, they won't be quite as prominent, and you won't see a swollen nerve typically with diabetic retinopathy. There are some exceptions to that, but in general, you wouldn't see those two things together, and nor would you see the type of tortuosity that you classically see with central retinal vein occlusion. And so with all of those other descriptors that you found, central retinal vein occlusion is going to be sort of most likely on this list for me.
The way I think about this too, and I know it might sound kind of silly, is when I think about an ischemic leg versus a DVT, right? All of a sudden it's pale and there's no color to it because there's an arterial occlusion, and that's how it looks like in a CRAO. And then if somebody has a DVT, they have a lot of edema, it's red and swollen, and then that's how I envision the CRVO. Mentally makes it a little bit easier for me, and I think about feast or famine. We'll move on here, and I'm actually turn it over to Dr. Weng to kind of focus on some of the next slides here because we're going to talk about the nuances of a differential for the RVO specifically. And Dr. Weng, I think you were getting into the weeds on this really, really well on that last slide, so I'm going to let you move on and continue.
Yeah, thank you, Dr. Hughes. I think that was such a great kickoff here. But, like you said, again, drawing back to what you first started off this session with, the differential diagnosis for ophthalmic presentations is so large. And honestly, considering when you think about a potential retinal vein occlusion, there can be so many other things with overlapping signs and symptoms. And here are just a small sample of them, to be honest. We already covered some of these nicely, but I want to delve a little bit more deeply into some of the most common potential conditions that you should also consider, and then point out some features that make them more or less likely. So we'll start off here and just sort of move left to right. When we're talking about central retinal vein occlusion, which is what you see first in that column, we're usually thinking a unilateral painless presentation of vision loss. That's fairly acute. So patients will come in saying they woke up and suddenly they didn't feel like their vision was the same. The level of blurriness can really vary drastically depending on whether it's partly a retinal vein occlusion, meaning a branch retinal vein occlusion, or whether it's truly affecting the entire central retinal vein. And obviously, if it's affecting the central retinal vein, more often those patients will have a more significant level of vision loss. But don't be thrown off, because not everyone is going to present with 2400 vision like this patient did. The other thing I want to point out is, again, just highlighting some of the features that you'll see on fundoscopic examination. The retinal vessels will be very tortuous. They won't be the general pattern that you see. They'll look more snake-like, and that should be one clue. A lot of times you'll see this blood and thunder appearance where you see diffuse retinal hemorrhages throughout the field of the retina. A lot of times you'll see a swollen optic disc. So when you're looking at the optic nerve with your direct ophthalmoscope, one of the things you should be looking for is how sharp or not sharp the margins are, because that can clue you into a number of different diagnoses. And then one thing we haven't talked about a lot yet, Dr. Hughes, is the pupillary examination, which can be really important. So you do want to check for an afferent pupillary defect and to check the reactivity of the pupils. And the reason that is because that can help clue you in down a different road, first of all, if it's not a retinal vein occlusion. But additionally, it can give you a little information about the prognosis of that particular patient's vein occlusion if they do indeed have one. And obviously, if there is an afferent pupillary defect, a lot of times the prognosis is not as good because it's considered an ischemic type. So those are some of the things that you want to think about. What about the risk factors? I do want to focus a moment on these. A lot of these overlap because, as you know, ophthalmology in general, our patient demographic tends to be more elderly. Elderly patients have a higher risk across the board of almost all ophthalmic conditions, but certainly with CRVO, that's one of them. But the other thing to look out for that we mentioned earlier are the cardiovascular risk factors: hypertension, hyperlipidemia, and diabetes, the classic American triad that so many patients have nowadays. If you see those, that even supports more the diagnosis of a CRVO or a BRVO, branch retinal vein occlusion. And finally, as I mentioned earlier and alluded to, glaucoma is also an associated risk factor for RVO. So those are all things you want to pay close attention to. We're going to talk about management afterwards, but a central retinal vein occlusion does require a referral to ophthalmology pretty promptly. I would say in 24 to 48 hours, you want to get these patients to an ophthalmologist, or better yet, to a retina specialist, so that they can be fully assessed, get all of the testing that they need that might not be available in the emergency department, and get started on treatment promptly. Because just like with any other disease, the sooner you start treatment, oftentimes the better the prognosis eventually down the line. Let's talk about some other potential differentials, though. And you mentioned this one, Dr. Hughes, the CRAO, or central retinal artery occlusion. The only difference between these two is one single word. It's vein versus artery, right? But you'll notice, just even looking at that index image, that it looks a lot different, right? There's not a whole lot of hemorrhages. It's pretty white, the retina. It looks almost pale. And you have this classic pathognomonic, what we call a cherry red spot. That cherry red spot represents the central macula, and it ends up looking like a cherry red color because of the pallor of the surrounding retina. And that happens because somehow the blood supply through the central retinal artery has been cut off. And there can be many different reasons why there is. One common reason is because of an embolic issue. For example, a plaque breaking off the internal carotid artery that ends up getting lodged in, distally into the central retinal artery can create an appearance just like this. Same risk factors with old age and cardiovascular risk factors, but one thing I want to share with you that is newer in the past couple of years in the guidelines of ophthalmology is, if you have a patient with a central retinal artery occlusion, they need to be referred immediately to a stroke center. And this could be you could save the patient's life, because this could be one manifestation of a lurking systemic stroke. And so that's the one takeaway I want the audience to learn about central retinal artery occlusion. Amaurosis Fugax is essentially when you've got transient vision loss in one eye. A lot of times it's related, it can be actually due to a central retinal artery issue too, or with carotid disease. So again, anytime you've got someone with amaurosis Fugax that you think could have a central retinal artery occlusion, best thing is to refer them immediately to a stroke center so that their carotid arteries can be imaged. They can receive an echocardiogram to make sure that there's not any impending threat to their life, to the rest of their body. That's going to be really important as well. A couple other things I just want to briefly mention because they're also really key. one of the common things I take care of is a retinal detachment. I'm a retina specialist. The retina is an organ in the back of the eye. It lines the back of the eye, and normally it's opposed against the back wall of the eye, known as the RPE and sclera and the choroid, right? But with a retinal detachment, for a variety of different reasons, including older age, including recent trauma, and one of the biggest risk factors is being nearsighted, which is an increasing epidemic in our world. The retina can actually come apart from the back of the wall, and it can start fluttering in the middle of the vitreous cavity. This is really an important one to note because it's going to look very different on examination. Instead of seeing the nice kind of orange reddish shade of retina, you're going to see a translucent white material that's floating around. And you sometimes have to look very peripherally into the retina to be able to see this, but there generally are not going to be the type of hemorrhages that you see with the central retinal vein occlusion. And I'm pointing out those differences because they can present similarly in terms of the patient's symptoms. It can be painless, it can be unilateral, and it can be sudden. So those are some of the ways that you can distinguish between these two. If a patient has a retinal detachment, they certainly need to be referred to a retina specialist very, very soon, within that day, because that can make all the difference in their visual outcome eventually and what we're able to do. I mentioned diabetic retinopathy, which is in the middle column there briefly earlier. Again, a lot of the similarities include the hemorrhages and the presence of exudates and hemorrhages that you can also see with central retinal vein occlusion sometimes. You can also see some dilated vessels with diabetic retinopathy. But again, the patient's pattern of the hemorrhages themselves is going to look a little bit different. It might not be as uniform. A lot of times they don't have a swollen nerve. And so that is something that you can use to help distinguish between diabetic retinopathy and CRVO. And finally, wet macular degeneration, another very common condition that affects some of our elderly patients. The big difference between this and central retinal vein occlusion is while you can see hemorrhages in wet macular degeneration, they're going to be usually affecting the central macula. They're not going to be in the periphery affecting all the different quadrants of the retina. Additionally, the risk factors, while some of them are the same, including cardiovascular risk factors and older age, this does have a female preponderance in terms of the demographics that it affects. And a lot of times these patients may have a history of dry macular degeneration that's now converted to wet macular degeneration. So it's something to ask them about and can help sort of lead you in the right direction. Now, I want to talk about the timing because I think that's so important when you're thinking about potentially seeing one of these conditions while you are in the emergency room, right? And I like to think of it in 3 different buckets. Is it something that you have to refer on immediately? Is it something that's emergent or same day? Or is it something that can be referred in the next 1 to 2 days? And I think that makes a big difference too for patients in terms of whether they can actually go home, whether they can get their affairs in order before going to the next place. And I think that's really important to be able to distinguish between these 3 buckets. I will say that starting in the left, the ones that you want to make sure you refer to immediately, refer to a different center or an ophthalmologist or retina specialist, include an acute central retinal artery occlusion for the reasons I mentioned earlier, with the new guidelines pointing to the fact that these patients need to straight go to the nearest stroke center. I actually, Dr. Hughes, had a patient the other day who came in exactly with this condition, and because they didn't have a ride and weren't able to see, we called an ambulance to take them to the nearest stroke center right across campus because, again, it's that important and can make the difference between life and death, and certainly between blindness and having some vision being able to be preserved. Acute glaucoma needs to be referred immediately to the ophthalmologist because there's a laser treatment that we do that can alleviate that immediately. If you leave them for just a few hours at high pressures with closed angle closure glaucoma, that can lead to irreversible blindness. So once again, power in your hands as the emergency physician to be able to really change the fate for these patients. And then of course, giant cell arteritis, they need to be started on steroid therapy right away. And that's also an emergency where I would send them to the hospital immediately. Do you agree with that bucket, Dr. Hughes, in terms of what you think about when patients come to the emergency room?
Fully agree. And we're going to get into the weeds here on how we improve our follow-up and connections. But I think what's really key here is that bucketing these, I think it's fantastic, right? Immediately emergent or same day and urgent within the next couple of days. Because as an EM physician, I need to be able to compartmentalize this stuff so I know what to act on right away. And I know what to seek guidance on for immediate treatment, right? It's great if I can give you a call and say, hey, I have a person with high pressures, and you could just run down the list of the meds that I got to start giving, like the bromotidine and all that stuff, because it could be eyesight saving, right? So I fully agree. I think your breakout is excellent.
Yeah, totally. And then in terms of same day, I'll let you read them there. And I know everyone has access to the slides as well, but things like infectious keratitis, that probably should go same day. Endophthalmitis is a really critical one that I'm sort of wavering between immediately and emergently on the same day between those first two buckets. That is an infection of the eye that can happen after surgery, after an intravitreal injection, and that can really progress very quickly. So, all of those on that list should be referred on the same day. And then let's look at the third bucket, because I really want to focus in again on our topic today, which is central retinal vein occlusion. That really falls into the 1 to 2 day bucket. For central retinal vein occlusion, different from central retinal artery occlusion. Central retinal vein occlusion, usually a couple of days, isn't going to change the prognosis drastically for the patient. But again, you do want to make sure that they have follow-up and close that communication loop. And I've also listed a few of the other common conditions that you may see that should be urgently or referred within 1 to 2 days there. Let's take a moment. You'll see a question pop on your screen. Go ahead and answer that. Now, I want to talk a little bit more about retinal vein occlusion itself, because I think it's one of the most fascinating diseases. First of all, let me just point out that it's the second most common retinal vascular disease, but it's sort of like the stepchild of retinal diseases. We don't talk about it as much as things like diabetic retinopathy and macular degeneration, but it is so common. That's the point I want to leave you all with, is this is absolutely something you're going to see in your career, if not a lot, while you're in the emergency department. The interesting part is that we don't actually fully understand why it happens. One of the leading theories for why a retinal vein occlusion happens is because the vessels that go through the eye, again, coming through, traveling with the optic nerve, branching off the internal carotid, then you get the ophthalmic artery, then you get the central retinal vein and the central retinal artery that feeds all the vessels that you see in the retina. But when you look at those vessels closely, the retinal arteries actually are on top of the retinal veins. And so part of what is thought to lead to a retinal vein occlusion is because of some either blockage or compression of that artery stopping up the retinal vein. And then all of that, that vessel gets engorged and basically spills out. That's why you see the hemorrhages is spilling out from it. So that's one of the leading theories. We already mentioned this briefly, but there's different types of retinal vein occlusion, as you see listed there. There's the branch, which accounts for 70 to 80% of cases, and usually, as I mentioned earlier, has a better prognosis, usually presents with better vision. We've got central retinal vein occlusion, which accounts for up to a third of cases. Again, more serious in terms of the visual debilitation that's associated with this condition, usually a poor prognosis. The most rare type is the hemiretinal vein occlusion, and you'll see that and know it right away because the hemorrhages will respect the horizontal meridian really linearly across the eye. So if you ever see hemorrhages either in the inferior or superior half of the retina and it doesn't seem to cross this invisible line, you'll know for sure that you've encountered hemiretinal vein occlusion. We've already talked about a lot of this, about the painless unilateral vision loss that you see. Patients can also sometimes complain of distortion of the eye because of one of the common conditions called macular edema that's often associated with retinal vein occlusion. We talked about an afferent pupillary defect and looking for that. And then again, I just want to point out some of the signs that I already talked about a couple of slides ago. But you'll see on the left a picture of the normal fundus and how the vessels emanate from a very crisply sharp optic nerve that's kind of pink in color, and then hugging the macula there centrally, which is slightly darker in color. Compare that to the image on the right, which is the blood and thunder appearance you heard Dr. Hughes refer to when we talked about the 67-year-old patient example that we are using. First of all, notice the vessels and how tortuous they are, right? Look at how much curlier they are than in the picture to the left. And finally, one thing you absolutely can't ignore are all of the hemorrhages that you see throughout the entire retina. All those red areas are areas of bleeding that have resulted from the retinal vein occlusion. One subtle thing that if you're more familiar with looking at these fundus photos is also if you look at the outline of the optic nerve, it's a little bit blurry on the outline, right? And that's because the disc is slightly swollen as a result of the central retinal vein occlusion. What are the risk factors? We talked about some of these, like older age, cardiovascular risk factors, having glaucoma, but I want to focus on the last three in that top box as we haven't talked about them as much yet. But drugs such as oral contraceptives or diuretics, things that can make your blood effectively thicker, right? More hypercoagulable, can lead to a central retinal vein occlusion, as can conditions that promote hypercoagulability like abnormal platelet function, vasculitis, and certainly smoking. Really one of the only modifiable risk factors here on this list. So if you are a smoker or if your patient is a smoker, be sure to advise them to ways that they can be moving towards smoking cessation, because that absolutely can lower the risk. And then, of course, if you see anything atypical that differs from that bucket of risk factors, things like bilateral appearance of an RVO, or maybe they're younger than 50, maybe they lack any of the common risk factors that we're talking about, or maybe they have signs and symptoms of systemic disease like hypercoagulability, that should really raise a red flag in your mind, and you should start looking down avenues for ways that you can work them up with or be worked up by their primary care physician for other systemic diseases. Another way that an eye condition can lead to life-saving interventions for this patient. You're going to see one other question pop up about risk factors for retinal vein occlusion, so please go ahead and answer that. And before I hand things back to Dr. Hughes, again, I just want to talk about the different ways that retinal vein occlusion can actually lead to vision loss. You can see on the left, it's not just macular edema, which is the most common. We talked about ischemia, the hemorrhage itself. And then from that ischemia, you can end up having a lot of neovascular complications, which can lead to vitreous hemorrhage, neovascular glaucoma, where vessels are growing abnormally in the front of the eye, causing high pressures, a different type of glaucoma. And eventually, because of these neovascular changes in the retina, you can even have something called a tractional retinal detachment, leading to separation of the retina. So all important things to remember for why retinal vein occlusion can eventually lead to vision loss. But of course, macular edema is the most common vision-threatening complication from retinal vein occlusion. And that's what we abbreviate as MEF-RVO. It's macular edema following RVO, and that can affect significant proportion of BRVO as well as CRVO patients down the line, if not immediately upon presentation. So with that, I'm going to hand things back to Dr. Hughes as we wrap up in terms of timing of treatment, and then I'm going to give you a really brief crash course on the various treatments that we have today in ophthalmology. Dr. Hughes.
That was fantastic. Thank you. And as the EM physician, I'm feeling more confident about performing my history, my physical exam, and identifying something like this and giving you a phone call and saying, hey, Dr. Weng, I have a patient with a central retinal vein occlusion. What do I do? And I think one of the important things to realize, and I think all of us do on this call, is that follow-up is really challenging and it's getting harder, right? I mean, up to 75% of people are going to require follow-up with an ocular presentation. And that makes all the sense in the world for the amount of people that we see. So many of them don't get follow-up, up to 40%. And so we all know why this is important: diagnostics, treatment continuation, getting them linked with care. But the question is, what do we do about it? So I think there's a couple things to do. Number one, increase trust. The better you are at doing your exam, the better you are at doing your history, the better you're going to be able to partner with your consultants, both in real time and having discussions about the patient in front of you. But, and this is where I kind of really love what I do in clinical affairs, is engagement with my subspecialty partners to say, hey, we have these buckets, immediate follow-up right now, critical, get the critical care ambulance over so we can get them to a high-level facility, immediate same day, 24 hours. What can we protocolize? How can we get real-time appointment scheduling? How can we set aside emergency appointments for folks? Determining the appropriate sense of urgency. These are the exact lectures that PeerView and ACEP bring to you all to get you to have an understanding of what that time frame looks like and how we should address these things in what order of emergence. Input from specialists in EMR leveraging. Try and partner with your EMR to figure out ways to automate these follow-up appointments, because these are the ways that we're going to start to be able to plug people into care better. So really important that we consider the time frame for follow-up, that we consider a prompt referral. As Dr. Weng alluded to, and I fully agree, address those modifiable things, right? Smoking has a risk factor affiliated with a bajillion different clinical entities that we see in the emergency department, and none of them good. So I think it is prudent to have a conversation with your patient about smoking cessation. Talk to them about their diabetes management. Talk to them about their hypertension management. Make sure they have a primary doctor. Get them affiliated with an insurance product if that's what makes the difference in terms of getting them in and getting them seen. But do what you can to help affiliate and align the patient with care, because this is what's really going to help in the long term. Follow-up is key. Communication is probably more key, not only with the internal ED team, but as well as with your partners in the community. So, I mean, we're talking about ophthalmology this evening, but we know that this blends into every other facet of emergency medicine, be it GI, be it cardiology, neurology, you name it. But I think what's really important is sitting down with your consultants and trying to find a way to create good pipelines between the emergency medicine space and the post-acute care space. And then also to partner in ways to find an opportunity to educate your patients and your clinical care partners. So as we're talking about Linda, she has a CRVO, Dr. Wang, and she has macular edema. And we know that this is not great for her, but we're proud of ourselves because we did a great physical exam. We did an excellent fundoscopic exam and slit lamp exam because we took all of the pointers from the beginning of the talk here, and we were able to successfully diagnose it. And I give you a call. What do I tell her? How long should she expect before she leaves? What are the long-term complications? I'm going to turn it over to you because I'm curious.
Yeah, absolutely, Dr. Hughes. I think there's a lot of questions that patients think about. And, what I would tell this patient is that fortunately, with central retinal vein occlusion, there are excellent treatments for one of the most common conditions, and actually for a lot of the different complications that can happen for macular edema specifically. We have wonderful treatments nowadays in the form of intravitreal injections. And so I want to talk to you a little bit about these, and I think some of the questions will be answered throughout these next few slides. But the first thing I want to tell you is that anti-VEGF agents have become first-line therapy for ME-FRVO, and they are the same types of injections that are used for other conditions like wet macular degeneration. These have been vision saving for many, many patients. And what they entail are medications, small amounts that are injected into the vitreous cavity that can help with the vascular leakage that's associated with the issues that cause the vision loss for these patients. Oftentimes, these injections are given every month to begin with, but eventually we try to spread them out as much as possible for the patients. Patients are often really fearful when they see these pictures online. I think what's important to tell them is that the needle is super tiny. I always tell them, if you take a look at one of your hairs, it's smaller than that. It's a tiny, tiny needle. We numb you up. So while you do still feel a little bit of sensation, it's really the most common thing I hear after someone's first time is they say, that wasn't as bad as I thought. And we do these right in the office every day. I actually just got done with a busy clinic day where I gave 25 of these injections today. So super common. Some of the names that you might hear that are currently approved for the treatment of macular edema from RVO include ranibizumab, aflibercept, and faricimab. These are tough names to say in ophthalmology, so don't be frustrated if you can't pronounce them. But if you ever recognize those on someone's chart, these are anti-VEGF agents that are used commonly. And additionally, they, like I said, have led in the registration trials to really impressive outcomes, patients gaining maybe even more than 15 letters in some cases. And that is because they have received treatment in a timely manner, which really starts with you in the emergency room upon diagnosis. We talked a little bit about this, but there are different types of therapies. There are the first generation therapies, and there are actually some newer therapies now, including faricimab, which is the most recently approved for macular edema from RVO. And all of them are effective. I think that's the main takeaway. But it's nice to have more variety and more options to choose from because the newer generation drugs may be able to allow patients to be treated less frequently, but with similar effects. That's one thing that we're seeing. And additionally, every patient is different, right? And I always use the analogy of shoes. Adidas might feel more comfortable to you than Nikes, right? And certain drugs in the eye may work better for Mrs. Jones versus Mrs. Smith. And it's nice that we have more outcomes. So that's really where I want to, I want you to take away from this. There was one study called LEVO. LEVO was a study that, interestingly enough, compared the three first-generation anti-VEGF agents that we have, bevacizumab, ranibizumab, and aflibercept, head-to-head for patients with macular edema from central retinal vein occlusion and looked at how they did at the end of 100 weeks. And the way it was structured is that they were compared to ranibizumab. And the conclusions were that aflibercept was non-inferior to ranibizumab at 100 weeks, meaning that the visual acuity outcomes were similar between those two. But they couldn't show that bevacizumab was not non-inferior to ranibizumab. And additionally, patients who were treated with aflibercept were able to attain those visual acuity outcomes with fewer injections overall. So the bottom line, again, is really just to emphasize that if you're having suboptimal outcomes with XYZ drug, let's say bevacizumab, you might consider a switch to another agent like aflibercept or like ranibizumab to see if the patient does differently. And that's, again, the beauty of having a lot of different options these days. One of the other categories of medications we also use to effectively treat macular edema from RVO are intravitreal steroids. These do have some drawbacks, including the promotion of cataract growth and the increase of intraocular pressure. Those are usually manageable, but definitely need to be noted. But steroids are sometimes really necessary and sometimes very effective, either to be used alone or in conjunction with anti-VEGF agents. So if you hear about that, that's another category of medication that we use. You're going to have another question pop up on your screen, and feel free to address that. And I want to make sure we save some time at the end for questions, but please, before we move on to that, let me summarize some key points here as we conclude this section. So first, remember that retinal vein occlusion is a common cause of acute painless monocular vision loss, and that the primary risk factors are older age and cardiovascular disease. So anyone who comes in with painless unilateral vision loss, you really should think about RVO because, again, it's the second most common retinal vascular disease. Prompt identification means prompt treatment, and that can really make the difference in terms of the patient's visual outcome eventually. It's also important to make sure you let them know that macular edema is something that, if they don't have at presentation, can develop over time, which is why it's so important to make sure that the patient has appropriate follow-up with either a retina specialist or an ophthalmologist within 24 to 48 hours after initial diagnosis, as Dr. Hughes really nicely said. And then again, tying in the communication between the different specialists, it's so important. Don't forget that there's one other important person in this triangle, which is the primary care specialist, who's going to be really key in making sure that their blood pressure is controlled, their cardiovascular risk factors are optimized, so this doesn't happen to the other eye or happen again, and maybe even work them up for systemic issues like hypercoagulability if appropriate in that situation. We are going to now move on to some questions. So thank you for that whirlwind, Dr. Hughes, really nice summary. And I learned a lot from your section as well from the emergency department standpoint. But maybe we can start with the first question here, which is, can you discuss the timing of doing these exams in the midst of a busy emergency department setting? How do you juggle performing these with other patient care demands? And I totally can understand this. I remember when I was in med school rotating through emergency, I loved it because it was so fast paced, so exciting. But you've got to be a supreme multitasker, and I know you are, Dr. Hughes. How do you juggle all these things in the midst of, also performing a slit lamp examination while you're getting other pages?
That's a phenomenal question. I'm really glad somebody asked that. I think it's like the first time I've been asked that question. And honestly, I treat it like any other procedure in the ED, which is the sooner you get it done, the sooner you're done with it. I've actually changed my clinical practice a little bit. Like if I have a person who I know I'm going to do a point of care ultrasound on, I bring that in and I do it as part of my physical exam. I don't treat it like a separate procedure. It is now just part of the package. And I find that that has actually streamlined a lot of my approach here. And so when I'm evaluating a patient with an ophthalmologic complaint, I will very frequently walk in with the slit lamp. And as I'm introducing myself and I'm going through the history and physical, I'm setting myself up at the same time. I found that that's increased my efficiency a lot. It's not easy. It's much like any other thing that we're doing is an augmentation to a physical exam, your pelvic examination, your digital examinations. There's a lot of sensitive exams that require a level beyond your traditional physical exam and just hands-on patient. And to that end, I think the more that you blend using your tools as a part of your physical exam to augment it, the more it's going to make it seem like just a seamless process as opposed to a completely separate thing.
Yeah, I love saying that. And, I love what you said about really what you do every day, you become good at and much more efficient at. So the more you handle the slit lamp, the less burdensome that's going to seem in the midst of a crazy day because you're familiar with it and you can probably get it done in a much shorter amount of time than maybe someone who's used it only a handful of times over the past year. So really, really great points.
It dovetails nice into this second question, actually,
Yeah,
because, I've tried the panoptic scope. It's
yeah,
okay. I
yeah,
think I like just using the regular fundoscopic
yeah.
exam, the regular otoscope or ophthalmoscope. Do you have any recommendations, or are there any things that like our departments ought to be looking out for to make these exams easier?
Yeah, that's a great question. We can look at the fundus in different ways, the direct ophthalmoscope, and then we have a helmet head indirect ophthalmoscope, which takes a lot of skill to learn. So I wouldn't recommend necessarily going towards that. The slit lamp also has a way of viewing the retina if you are able to hold a lens and sort of direct your beam towards that. But again, I think that's really something that falls more into the skill set of ophthalmologists because it takes a long time to even learn that even in residency training. So I think you're right, Dr. Hughes, that the direct ophthalmoscope is probably going to be your best bet. But again, I can't stress enough, considering dilating the patient in the emergency room, I'm telling you, that will make a world of difference for your ability to see and your ease and comfort with that procedure. The other thing I'll mention that I don't see a great adoption with yet, but we have a lot of excellent imaging modalities now that can take pictures of the fundus with a single snapshot of a camera. And you don't even need to necessarily dilate patients for that. I don't think they've made their way into the emergency rooms yet, probably because ophthalmology still represents overall a smaller fraction of the things that are seen in the emergency room. But I'm hoping as the cost of those machines go down, that potentially that could be integrated, because that will allow you to see the retina probably as well as we're able to see it, with a couple seconds and a snapshot of the camera. So technology is really advancing, and I do hope we're able to make progress in that area as well.
So I'm not seeing CRVO all that often in the emergency department. The epidemiology we commented on a little bit earlier, it's not that frequent, but I think the history and the physical really will drive you to that as a potential etiology of the patient's vision loss. I do want you to ask answer, Dr. Weng, if you could, that fourth question: what is the risk of precipitating acute glaucoma if we're doing a dilated exam? I gotta be honest, I haven't thought of that much.
Yeah, that's a great question. And it is absolutely one of the risks. I think that the two risks that people should think about in dilating are some sort of allergic reaction that the patient could have. This is very rare. Or if you use a really strong dilator, it can sometimes have effects on the heart. So there are very, very small risks. These are all far less than 1% that could happen. The bigger risk, honestly, with using dilating drops, and the reason I alluded to the fact that some emergency medicine doctors may not necessarily feel comfortable, is that it can precipitate acute angle closure. Generally, for those patients with a shallow anterior chamber who are already prone to developing acute angle closure, for example, patients who are very hyperopic, or patients who are Asian demographic women, those are groups of people who generally have a shape of the eye that makes them more prone to acute angle closure. Dilation can absolutely precipitate that. The important thing is that if you ever are in that situation where that occurs, again, you'll want to be able to recognize it, because they'll have sudden pain and potentially vision loss and halos around lights, and get them right away to the care of an ophthalmologist, because we can treat them immediately with a single laser procedure that can help reverse that angle closure. But the risk that I've seen across the board has been 1% that's going to happen. And a nice way of maybe assessing that risk, Dr. Hughes, is by asking the patient, have you ever been dilated before? And if they have, and that's not been an issue in the past, it's very likely not going to be an issue when you dilate them again. For a patient who's never been dilated before, or maybe has had issues in the past, those are the ones you'll want to be a little bit more cautious with.
Yeah, that's a great summary. I think that's awesome. And I love that you're treating it as like, have you ever had X procedure done before?
Right.
See what your tolerance is. We do that with allergies. We're going to finish up, folks, with just question 5. So if you're still with us, thank you so much. I know we're just a minute over. This was too much fun, and I think that's part of the problem. But the question, Dr. Weng, and this is probably a broad answer, so we'll try and thin it down a little bit, but are there any time-critical interventions we can do when a person presents with retinal emergencies? I think, for me, the big takeaway from this is to A, get your diagnosis as correct as you can by a great history and physical exam. Once you've honed into that diagnosis, time is a factor, and coordinating with your specialist is a factor. And so the more you can get to yourself to the point where you can make an accurate diagnosis and get in contact with Dr. Weng and her associates and say, hey, I got X, Y, and Z thing. What can we do about it? Next steps. There are some things like a CRAO, you could do ocular massage with the thumbs. Their high oxygen therapy has been looked at in this pathology as well. None of them are really definitive treatments, certainly, and none of them have been really proven to be overly effective. But I mean, if I'm in a rural emergency department, these are things that I'm going to want to be aware of. And so I think it's a great question. Dr. Weng, anything else we should look out for if we are in a rural emergency department very far from specialists that we could do to temporize things and kind of set them up for success when they're ultimately transported?
Yeah, it's a great question. I think one of the other common things is a retinal detachment. And what I usually do in those cases is have patients lie flat on their back and keep their eyes closed, because we know that frequent oscillations or even gravity when patients are sitting straight up can sometimes affect the prognosis and further detach the retina. So that's one thing that's pretty simple. But I agree with you, Dr. Hughes. The biggest thing you can do is to recognize what the patient has and get them to the next specialist who can really definitively take care of their problems as soon as possible. possible. I would say the one exception to that, again, is a CRAO, where a patient needs to immediately begin stroke workup. And again, that can be something that changes someone's outcome in a very dramatic way. So like you said, it's always so fun. We could go on and on for hours more, Dr. Hughes, but I want to thank you today for joining me for this program. And be sure, as you see on the slide, to visit us at peerview.com/retinal-emergency-25. Remember to complete and submit your post-test and evaluation so you get credit. All of these slides that Dr. Hughes and I presented are going to be available to you for download, as well as some practice aids that I think you're going to find really helpful. So be sure to take advantage of that. And then remember, you can watch a replay of this entire conversation if there's something that you missed in the next 24 hours, and as well as being posted as an online activity in the coming weeks. Again, thank you to PeerView. Thank you to the emergency medicine group as well for supporting and executing this program today. And thank you to Dr. Robert Hughes for joining me.
Thank you all so much. This was a lot of fun. I hope we answered some great questions for you, and we'll see you later.